this lecture at 1, and I think it's best if we do it interactive, so we'll have you guys participate. So the definition of shoulder dystocia is there, but kind of in layman's terms, someone describe shoulder dystocia for us.
Shoulder gets stuck, it doesn't come out
Where does it get stuck?
under the pubic bone.
Yep, it's under the maternal pubic symphysis. Yep. So usually you have fetal head delivery followed by impaction of the shoulders. Okay. Truly obstetric emergency. What are some of the things that could happen to the baby, like if there is a shoulder dystocia?
Well, you can get, he or she can get stuck and not be able to breathe and drop
Yep.
heart rate.
So decreased oxygen. Yep. So long term that could result in admission to the nursery, prolonged neonatal resuscitation, cerebral palsy long term. Okay. What else could happen to the baby? Not facial nerve, but brachial plexus injury. So this is called Aird's palsy. This is called Klumpke's palsy, I think. Like if you see the hand just kind of dangling like this, that's nerve damage. That's from the overstretching of the brachial plexus, which kind of comes from the neck. Okay. And then obviously fetal death is going to be a big risk factor. Okay. So now we know what shoulder dystocia is. Can they see this online too? Whoever's watching remotely?
I'll send it to him.
Okay.
Yeah.
Yeah, you can read the definition. I don't think we necessarily need to review it now. What are some risk factors for shoulder dystocia?
Large, growth, a large baby.
Yep, so large for gestational age or macrosomia.
So any mom who's got GDI.
Yep, so gestational diabetes, type 2 diabetes, type 1 diabetes, even maternal obesity. I don't know if I included that last time.
I think you did.
Okay, other risk factors? And maybe it's not a pre-existing risk factor, maybe it's a risk factor you identify intrapartum.
Like small pubic bone or?
I don't know if that's necessarily a risk factor for dystocia. That might be more of a risk factor for like an arrest of the second stage of labor or something like that. What if you had a multip who's pushed for 2 hours? Prolonged second stage. Okay. Maybe you're starting to worry about like, what's going on here. Why is this taking so long? What's wrong? And maybe really what's wrong is it's a big baby. Maybe this baby doesn't fit. But if we keep pushing it, where are we going to end up? What are some signs of an impending shoulder dystocia? Turtling. Okay, Katie, describe turtling for us.
So just that rocking back and forth, it's not gonna be dramatic, just not gonna.
Yeah, and so what makes it go this way? What makes the fetal head? So mom's pushing, and then maternal expulsive effort stops, and the head retracts. So that's mom pushing it down, but it doesn't fit, so it pushes back. Does that make sense? Okay. Anything else you can think of?
Post states is another risk factor.
Yeah, good, okay.
What do you say? Post states, risk factor.
So again, just giving the baby more time to grow. Yep, okay, good. Can we switch to that helper mnemonic screen?
Yeah.
So this is the helper mnemonic, and this has been included in your guys's, the little flip cards that are right when you pull out the drawer for the gloves. It's right there. And I think this is really important. And I don't know that you necessarily need to have it open during a dystocia because you're going to be so busy. But if you have time to and you want to flip it, that's great. But maybe just having it there and reviewing it on a regular basis is going to be helpful. Okay. So the first thing to do.
Oh God.
First thing to do when you have a shoulder dystocia, it's call for help. And so, and you want to identify it clearly to the patient, to the nurses, to the other staff in the room. Okay. When I was going through residency, which this was, over 10 years ago now, it used to be like kind of like, you're kind of like under your breath a little bit about it. And studies have shown now that if you're like clear and concise about it, you actually have decreased risk of the patient suing you later. So always be transparent with your patient. If it's postpartum hemorrhage, tell them you're having a postpartum hemorrhage. This is what we're doing. Okay, and they're actually going to really appreciate that. So always be transparent. So call for help. Let everybody know. Like say out loud in the room, we have a shoulder dystocia. Okay, this is what whoever's delivering should do. So we're going to go through this HELP. So the E stands for consider episiotomy. Obviously something your provider is going to do. Why do you think we would consider episiotomy?
Give more room for.
Not necessarily. Yep. Yep. Yeah, for enter maneuvers. So actually you can get your hands there. So in a way it's giving more room, but the episiotomy is not going to free up the dystocia. Okay. So the dystocia is a bone-on-bone impaction. So by creating more soft tissue room, you're not freeing up that bone room.
Okay.
Does that make sense? But it's so you can get your hands in there. If the patient's had a couple babies before, you may not need that, but if it's the first time mom, you may. So it's just considered. Doesn't necessarily mean that if you identify dystocia, you gotta make the episiotomy. Next one is L for legs, and that's the McRoberts maneuver. Can someone describe the McRoberts maneuver?
You put the head flat, you pull the legs back and to
Yep.
the side.
Yep, so you're hyper flexing the hips. So mom's already probably in a lithotomy position, probably pulling back her own legs. A lot of times we have a nurse on one side and the patient's spouse or partner on the other side. Try to get 2 nurses. Okay, so you've already called for help, so hopefully the whole team has ran in. Whoever's available on the floor is coming to help you. Get another nurse over there and really hyper flex the hips.
You can kind of see it on this guy.
Yep, and see how that kind of made that pubic symphysis roll forward? It may be just enough to dislodge that anterior shoulder. That's actually a really great schematic. I like that one.
This guy.
So knees to the chest is what they're describing. Cephalad rotation of the maternal pelvis and flattening of the sacrum. So next is suprapubic pressure. Okay, let's describe that.
Like that picture where you just
Yep.
have to push.
Yep.
And isn't it like kind of pretty forceful? Like,
It's not kind of pretty forceful. It's, we gotta get this baby out
Yeah.
forceful.
Yeah.
You guys actually push really hard for fundal checks, right? I want more pressure than that.
Okay.
If you're doing suprapubic pressure, you better be pushing the shoulder underneath the pubic bone. Yeah, so it's aggressive. And they showed it like that in that video. I actually don't like that. I like, yeah, almost like a fist down technique. I just feel like that is like almost like too flat. Yeah, too like a dispersed. Yeah. I guess if it works, I don't care how you do it. Please don't body slam.
And just because we talked about this in the other class, I brought up good points. Can I do fundal pressure?
Yeah. So what do you guys think about fundal pressure during shoulder dystocia?
Probably not very helpful. You're just creating more bottleneck.
Yes, 100%. So I'm really
Nice,
glad that you
Rose.
figured that out on your own, Rose. But probably in eras prior to even my training, they used to use suprapubic or fundal pressure. So really, do we ever use fundal pressure? And the answer is no. No. Occasionally, I may ask for it if I'm trying to break the water, just so I can get I can feel the bag or get a little fluid in front of the head. But it's not indicated for anything. If your provider asks for fundal pressure, you should look at them with a funny look. Yeah, and then you should say, what do you need that for? Because it's never indicated.
When is the only time you'll see the physicians do fundal pressure?
Man, you really took notes last time. Good job, Marvin. Good job, Katie. Yeah, it's the only time we
Good for us.
use it. Yep. Okay, next are entry maneuvers. So this is where the provider, midwife, doctor is actually going to get their hands inside to help deliver this baby. So we've got a couple videos we're going to watch.
Yep. Okay.
So this is the posterior arm release, and actually pause it real quick.
Yes.
So the baby's inside, right? So what you're doing, the posterior arm is, let's just say it's down, the baby's coming out. So I'm putting my arm in and I'm trying to sweep the arm up, across, and out, okay? And I kind of did this in the room, so you can see how wide my shoulders are now, right? And so if I raise one, which was wider? This way or this way?
The other way.
No,
First.
oh, the
That's
shoulders
wide.
wider this way.
Yeah, that's what.
Yep, this is why. So by raising that arm up, you decrease that biacromial distance. So from one acromion to the other. The acromion is this point on your clavicle. Okay.
You will be required to lubricate. And if you are, you will be required to
Labor delivery's calling.
your hand into the duct. Slip it posterior versus the bottom of the baby.
You weren't on call, are you?
Hello?
Gently,
Hey, sorry.
my hand all the way up to the baby's hip. Grabbing the wrist like an okay sign.
Restart. Yeah. This guy, Ruben.
Perform the Rubin 2 maneuver. Take 2 fingers behind the posterior shoulder.
It's actually the anterior shoulder. That's a mistake in the video.
30 degrees towards the baby's face. In the real world, someone will be applying suprapubic pressure in this direction.
So the Rubin maneuver, what I learned was shoving shoulders saves scapulas. Shoving shoulders saves scapulas. Yeah, she even saves shoulders, whatever. Anyways, the whole idea is, again, so biacromial distance, by compressing one shoulder and kind of rotating that baby, you're helping decrease this acromial distance and pop the shoulder out. And that is actually really hard. He's making it very, with 2 fingers. I have my whole damn hand in there trying to do this.
Okay. And then got the woods. This one is filmed very awkward, so let me put it as the big boy. There we go.
The anterior shoulders are the arms.
The anterior field shoulder. Next portion of the procedure is to put 2 to 3 fingers on the interior front side of the posterior field shoulder, and then rotate the baby 180 degrees.
Poor vagina. It's just shattered, along with her dreams.
Once the rotation has been completed, the baby should move.
Should. That's a big baby.
A real big baby.
So that's Wood's corkscrew.
And then I think that was the oh yeah. Then we
watch a posterior arm.
that's the one that first one I think.
Okay, then I stepped out. Okay, sorry. Okay, so sorry.
This one, yeah.
Yeah.
Do you want to watch it again? Okay.
The last one, the R, this is the gasket maneuver. Rotate the patient to our hands and knees.
Yes.
Again, if your patient has an epidural or is immobile, you're not gonna be able to do that. But getting the patient on all fours sometimes, again, basically what it's allowing you to do is deliver that posterior arm easier because you've taken the pressure off of the posterior side now. So things you can try. One thing that Susan brought up in our last class was that if she was to encounter a shoulder dystocia and the provider is not there, chances are the mom doesn't have an epidural because the provider's just missed it. Roll them on hands and knees, okay? And then all you have to do is just gently traction down the head and you should be able to get that posterior shoulder. Not always, I mean, if it's a big baby, everybody's gonna struggle, but something you could do as nurses. The other thing we talked about is, what if you're delivering the baby unassisted and you can't get the shoulders out? Call the ER doctor. They're probably not gonna know what to do either, in all fairness, but that's someone that I could talk to on the phone and try to talk them through it as I'm coming in.
And then these three were the
So abdominal rescue, I've never had to do this, and I've never seen them talk about it, but basically the head is out and you basically do an emergency cesarean and you're pushing physically and manipulating that shoulder. Yep. The Zavanelli removal or maneuver or cephalic replacement is literally pushing the fetal head back inside. Yeah. Anybody who's done obstetrics long enough knows that's pretty scary. Susan did tell us in our last meeting that she's seen it one time in 30 years perform successfully. But she said it was done very easily. So I don't know if the head was fully delivered. I suspect it wasn't. It may have still been maybe a little bit in the vagina. Mm-hmm. But instead of pushed up easy, they did a C-section. And the baby did go to nursery, but recovered fine. Intentional clavicular fracture, I have had to do this before. This is very traumatic, but the clavicle heals so well. So, and actually what we did is we put a ring forcep on the clavicle and broke it. You can try to push as hard as you can by pushing under the clavicle and up. It's hard. Or even just pushing straight down on it. And eventually it gives way. But it's a lot of force. It's not something I want to do. The other risk factors for the baby, if they experience a shoulder dystocia, clavicular fracture, humeral fracture, brachial plexus injury, oxygen deprivation, cerebral palsy long-term, but probably more commonly is that decreased time with mom initially, neonatal resuscitation, moving to the nursery. Yeah.
This is a video we watched last time to kind of give a better visual. Sorry about the ad that's going to play. And then we're going to talk through a scenario that recently happened on our unit with a shoulder dystocia. Yep.
This is good just to kind of see what's physically happening.
Did I pause it? What's going on here?
Free up space to continue. Choose sites to clear. Oh, there it goes.
I think it's talking, but for some reason the sound doesn't.
It doesn't look like that. Don't watch that part. Usually don't with a pair of scissors, but okay. Actually, that's really high PVR. I have to take it down there.
But this part is what we like to see
Yeah,
here.
see that brachial plexus stretching? So as mom's pushing, there's maternal expulsive effort, and then see the head trug back? That's turtling. So mom's pushing baby out, and then it pops back in. And if I was leveraging that head downward a lot, I'm gonna cause brachial plexus injury. See how you can kind of see that?
And he's out.
But they didn't do any anterior maneuvers.
No. But at least you see like what it looks like from the inside.
Yeah, so we had a scenario, this was a couple months ago. I'll give you the patient's kind of background. So this is a 21-year-old G2P1 Hispanic female. Her first child was born at like age 14 or 15, I believe in Mexico. She does not speak English. She was seeing us in the office. She failed a 1-hour glucose test, passed a 3-hour test. Her BMI is probably 35. And she had a recent ultrasound that showed like 60th to 70th percentile for estimated fetal weight, so fairly normal, slightly above average. She was a little bit past her due date and was undergoing elective induction of labor. So let's just identify some risk factors for shoulder dystocia for this patient. So BMI, yep, that falls into that overweight and obese category. Okay. Faster due date, yep.
I mean, even though she passed her 3 hours,
Yeah.
she did fail the
She
1
probably
hour.
has some glucose intolerance, okay? She's Hispanic, that's a risk factor, mainly because they have high risk for diabetes. And then the other information I tell you is, Liz was, and I'm telling you, it's very clear who took care of this case. It's me. Liz was managing her, and she'd been pushing for well over an hour. This is a G2, so she had a prolonged second stage. And Liz was calling me to assess for a vacuum delivery. So the other risk factor for shoulder is operative delivery and a multip. Okay. So I came and assessed and did the vacuum. We had 2 pop-offs, and then we delivered the fetal head, and we had the ugly shoulder dystocia. Everybody ended up doing great, but I think what we did was definitely McRoberts, suprapubic, Woods corkscrew, and Rubin maneuver to get the baby.
Which one ended up working?
I have no idea. All 4 of them.
Just everything.
It happens so fast. Yeah, but I believe I said, and this was fairly chaotic. This is why we reduced the number of people in the delivery room. Were you there for this one? Yeah, that's too many people. But since the patient didn't speak English, who knows what they were telling her? Oh gosh.
Yeah.
Screaming over everybody.
Yeah.
Yep.
And we did consent her, like, I remember this now. Do you want a C-section or do you want to try this vacuum? Like, we let her try. And at one point she wanted a C-section, and then she wanted the vacuum. It was very effective for her. At the end of the day, everybody did good, but it was probably a 2-minute dystocia.
And you told her no more.
I told her no more babies.
No more, at least
No
no
more
more
vaginal.
vaginal.
Yeah, I sure did.
So this might be a dumb question, but
Yeah.
if you end up going to C-section to get the baby out, then is it still difficult? Like, is it still going to be stuck for you a little that way?
It depends. If they've been pushing for a long time, even just trying to get that head back out of the pelvis, yeah, absolutely. And sometimes I'll have a nurse push from below, like actually put her hand in the vagina, and you have to push hard. It is not like a gentle, like, oh, no, I mean, like, you have to unwedge. Like, a lot of times you'll hear the suction, like, break and everything. Because because the angle that I have when I'm in a mom's belly is like this. I'm trying to pull up. Like, this is what my arm is doing. How much strength do you guys have like this? Okay, versus how much do you have if you're going like this? So that's why the nurse below, so if I ever ask for a mold, that's why I don't know, like the mold pushes from below or whatever. Or if I ask you to get a glove on and push this baby's head up for me, I'm asking you to really, truly push, like, everything you got. And I've had a nurse tell me for a while, I want to hurt the baby. It's like, well, if we don't get the baby out in a timely fashion, then we've done injuries.
And the clinic has a rule, it's like if you're diabetic 4,500 grams is
So this
automatic
is a
C-section.
ACOG rule. So if you are a diabetic, whether it's type 1, type 2, or gestational, if your estimated fetal weight at the time of delivery is 4,500 grams, it is recommended to have a cesarean due to the risk of shoulder dystocia. And that's about 9.5 pounds. It might be close to 10. If you are not a diabetic, the recommendation for primary cesarean is 5,000 grams, which is 11 pounds. So it is super lenient, okay, meaning like they want to give you every chance to have a vaginal birth. Some women can have a 9 pound, 15 ounce baby.
9'9".
Thanks for volunteering.
It is possible.
Did you
100%.
recently have a shoulder dystocia?
No.
Oh, okay.
Yeah, and so that's why probably when you were going through labor, you didn't exhibit those features. Yeah. And that's the other reason we don't do, that's why everyone enrolls in labor and delivery doesn't have an estimated fetal weight, because we probably end up, you would have got sectioned for sure. Was your first baby 9 something?
Mm-hmm.
Yeah. That would have been highly unexpected that you could deliver it.
Good for you.
Thanks.
Yeah.
90-10 rule, 90% commit, 10%
Do you guys have any shoulder dystocia related questions before we switch gears?
Does somebody's had like shoulder dystocia before in like their first pregnancy? Do you recommend that they get a C-section?
I think it depends on the situation. So that's another risk factor that we didn't mention is risk factor for shoulders, prior shoulder. So I think it depends on the situation. For this last patient that I told her no more babies vaginally, all C-sections if she has them. I know she's not going to make a smaller baby because she's already at 21, overweight, sedentary, just chances are she's going to continue to make big babies. I have another patient who's had an 8-pound baby vaginally, a 9-pound baby vaginally, and then she had a 10-15 that required a C-section. And she's pregnant again with number 4, and she already has diabetes. We're at I think we're 12 weeks along. And so chances are she's going to get recommended to have a C-section. But she doesn't want to. She's had 2 prior vaginal births and 1 C-section. So now she's a VBAC. Yeah. And so her, what we knew with her is she progressed to 9 centimeters and would not progress to 10, would not progress to 10. The head would not descend, and we ended up doing a C-section. And we knew the baby was big, we just didn't know how big it was, 10, 15. Wow. Yeah. And she failed her 1 hour, passed her 3 hour. So this time we didn't even do a glucose tolerance test. We just made her start testing her sugars, and they're all high.
And then, do you want to touch on the postpartum hemorrhage risk?
Yeah, absolutely. So if you have a mom who has a shoulder dystocia, be prepared for the coming up postpartum hemorrhage. So now the mom has probably had a prolonged labor. Maybe she's had a hard delivery. Maybe she's had a 4th degree, so the hemorrhage could come from laceration. And it could be, like I saw in the last group, 4th degrees don't tend to bleed that bad. It's those sidewall tears. It's the deep vaginal tears that are a problem. Perineal injuries usually do okay, not always. So it could be bleeding from a laceration. It could be uterine atony from everything the mom just went through. So just kind of be prepared. Also, Susan brought up a good point. Be prepared for full-on NRP. So once you announce, let's just kind of talk through this. Once you, are we going to go to the room and do this part?
Yeah, but go ahead.
Okay. So let's say your provider says we have a shoulder dystocia, and let's just say you talk around me, your first name.
Callie.
I know it. Sorry. You're the lead nurse, and I look at you and I said we have a shoulder dystocia. What should go through your mind?
We need to get help.
What do you do? How do you get help right away?
You can hit the call button.
Hit the call light or pull the emergency cord. Yeah, everyone comes running. You pull that cord out of the wall, right? So get the team in there. Good. Okay. Yep. And I've said it out loud. You can say it out loud again when the team comes in or something. But yeah, get help. Truly treat it as an emergency. And then the one thing Susan said is, whoever comes in, tell them to get baby meds ready. Just be prepared for NRP. Call the pediatrician. And the pediatrician may argue with me that not all shoulder dystocias end up with a bad baby. You don't know that. Right. We've got 2 to 5 minutes before this kid comes out, most likely. And 2 to 5 minutes of being down is bad.
And what dose of epi are you giving to a baby through a UV or a PIV? Say it louder.
Go through a PIV?
Louder. 0.2 per
Okay.
kilo.
I was gonna say.
Yep.
So the peripheral IV?
Yep.
Well, we're probably not going to have one of those.
You never know.
Okay.
But if you have one, use it. If you have a UV, even better, use that. You won't have an IO. So.
We have ions in our crash cart.
Yeah, but in this, you're better off putting in a UV than you
Yeah,
are taking
sure.
the time to put in an IO. Yeah. 0.2 per kilo for epi. Okay. Do you think we covered?
So, was there another question though, or did you have another?